Welcome to the Culture Stew podcast. I'm your host, Maria Morukian. Throughout my career, I have supported leaders and organizations in their efforts to build thriving cultures that are strengthened by diversity, equity, and inclusion. Hi, everyone. I am so thrilled to be bringing you this latest podcast episode because I had the honor of speaking with my friend, Dr. Carolyn Sufrin. As the leading expert on reproductive healthcare for incarcerated women, Carolyn is a force of nature. She's a professor of gynecology and obstetrics at the Johns Hopkins University School of Medicine and of Health, Behavior, and Society at the Johns Hopkins Bloomberg School of Public Health. Carolyn earned an undergraduate degree in anthropology at Amherst College, followed by a medical degree at the Johns Hopkins University School of Medicine. And then, just for kicks, she earned a doctorate in medical anthropology from University of California. When she was in California as part of her work to support reproductive health for women, Carolyn started a women's health clinic at the San Francisco County Jail, which continues to this day to provide care for incarcerated women. And based on her ethnographic research with workers and pregnant women at the jail, she wrote and published the book Jail Care: Finding the Safety Net for Women Behind Bars. Carolyn is also the director of the Advocacy and Research on Reproductive Wellness in Incarcerated People program, which conducts NIH and foundation-funded research on issues such as pregnancy outcomes in prisons and jails, and medication-assisted treatment for pregnant people in jails, and contraception access in carceral settings. Just this past summer, Carolyn testified to Congress on the injustices and abuse women face in the prison system. She is an absolute warrior for equality and justice, and one of the smartest people I have ever known. And she's also a deeply kind and generous spirit. So for all of those reasons and more, I hope you enjoy my conversation with Dr. Carolyn Sufrin. Well, hello, Dr. Carolyn Sufrin. I'm
excited
Maria. To have you on today, and it's fun to be able to call you Dr. Sufrin instead of just Carolyn, as we normally have had interactions in a more informal way.
Well, you can still call me Carolyn today. But yes, I am a doctor, not on TV.
Well, thank you so much for coming on today. I can't tell you how excited I am to have this conversation and to learn from you, particularly just thinking about what we're prioritizing and focusing on this season, and also just everything that is happening from a societal and policy perspective in our country. I think that the work that you are doing is so profoundly important, and we're going to learn a lot from you. So thank you for taking the time.
I'm excited to be here.
So my first question, I would love to first and foremost just get a little bit of your backstory. If you could share with our audience, what drove you to not only join the medical profession, but to focus on gynecology, on obstetrics, and particularly on reproductive health care for incarcerated women?
Well, I always knew that I wanted to go into OBGYN once I knew I was headed for a career in medicine. Just very interested in reproductive health care and always committed to reproductive rights, especially abortion care, even before I went to medical school. And so the field of OBGYN was a natural choice for me, given my interests in advancing sort of the full scope of what I didn't know then was reproductive justice, but what I now, thanks to the teachings of Black feminism and the leaders of reproductive justice, that I know to be the core rights of reproductive justice. But what in particular led me to clinical care and then research and advocacy with incarcerated individuals and their reproductive health care was an experience I had when I was in my medical training. I had graduated from medical school and was doing my residency training in obstetrics and gynecology. and I was a first year resident. And when you're a first year resident, also known as an intern, you're learning the ropes, and you're learning the basic things. And when you are on call, you're mostly helping to deliver babies, and taking care of pregnant individuals. And one night when I was on call, I got called into a delivery room. And as this new doctor, there was sort of one thing that was going through my mind, which was, let me just make sure I'm not going to drop the baby. That's like, as a first year resident, that's what you are trying to avoid, and doing all the right things to help facilitate a safe birth. But what I was not prepared for when I walked into the room was the fact that this new mom, or mom to be, was shackled to the bed. And this is nothing that your medical training prepares you for. There's no formal training in caring for this population, and nothing I'd ever learned at any point in my training, whether in college or medical school, had prepared me for the idea that there were women behind bars, let alone pregnant individuals. And so this moment in the delivery room was really jarring for me. Of course, much more so for this birthing individual than it was for me. But I wondered so many things, like, what would I do if there was an emergency? And did I have the authority to ask the law enforcement officer in the room to remove the restraints? I might have, but I certainly didn't feel empowered to, and I was just so overwhelmed and confused. And then I thought about my own complicity in this act, that I didn't ask them to remove it. And I also wondered, like, why is there a pregnant woman in prison or in jail? And at the time, I actually didn't even know the difference between prison and jail. So it just, for me, being part of this intensely traumatic and also life-giving process of giving birth in chains, for this woman, being part of that process for her, opened up a whole Pandora's box for me, and really resonated with the social justice reasons that I went into medicine in the first place. And I started to learn more about women who are incarcerated. I began to learn more about healthcare for incarcerated individuals and what it looks like. And then over the years, as I went through my training and moved to different places, I eventually began actually providing healthcare in a jail, which I did at the San Francisco jail for nearly 7 years as their OBGYN. But it was really that moment with a patient, and being part of this very troubling event that spurred me onto this path.
I thank you for sharing that. I remember when I first heard you share that story, and it just rocked me back on my heels, because I think particularly for any of us who have given birth, and you think about what a you know joyous and also potentially very traumatizing experience. It's like all of the above, right? But that's for those of us in the best of situations, who have had the opportunity and the autonomy to determine every detail in some ways of our birth plans, and
Mhm.
how it's going to be and what music we're going to play. And I mean, it rocked me on my heels, because I thought about, holy moly, it just never occurred to me. And I think that's one of those things that we often find ourselves face to face in doing equity and justice work, is that those moments when we realize this wasn't even on my radar, because I have so many compounding societal advantages. I was unaware that
Mhm.
um, that these types of situations could be happening, and happening in so, it's not just happening to one or two people. This is endemic. And so I'm
Mhm.
wondering if you could share a little bit, Carolyn, about what are some of the, in your research and in your work, what are some of the pervasive issues that
Mhm.
women who are incarcerated are facing when it comes to reproductive health?
Well, the first one that I want to address is actually what you just said, and what I described was being unaware, because that is pervasive. It's not just as a society, oh, I never thought about this. And there are all kinds of reasons why we wouldn't be, it's kind of a cognitive dissonance to think about, life-giving processes of birth in a place that's so harmful and violent as a prison or jail. But there's a statistical erasure. So we actually have no
Wow.
idea how many pregnant individuals there are in US prisons and jails. And I didn't
Really?
really think about that until I had been doing this work for almost 10 years. And although I had written some articles and spoken publicly and would occasionally cite some statistics that 3 to 5% of incarcerated women are pregnant.
Mm,
I realized when I looked at those citations that they really didn't come from anywhere
mm,
valid or you know, rigorous statistics, and that they came from a very limited study that was done in like 1999.
mm,
And so my research team at Johns Hopkins conducted the first ever national study of to try to quantify how many pregnant individuals there were in custody, at least in a sample of state prisons, and how many gave birth, had miscarriages, abortions, and other outcomes. And this study, which we call the Pregnancy in Prison Statistics, or PIP study, we conducted it from 2016 to 2017. That's like pretty recent to have the first national estimates. And it wasn't even all 50
yeah.
states. And it certainly wasn't all 3,000 plus jails in the United States. But we did have 22 state prison systems as well as all federal prison systems participate. And we estimated that there are about 58,000 admissions of pregnant individuals to prisons and jails each year. And
Mm,
in our study, at just this sample, there were at these jails and prisons over or nearly 1,000 births that happened in this one year, and a couple hundred or a little over 100 miscarriages, and a very small number of induced abortions. And so when you talked about the research and the needs, just even documenting that they exist is essential. Because when we don't have data to prove that they exist, then we as a society and prisons and jails as facilities can say, well, there aren't that many of them. We don't need, we don't have any. Then it allows them to not have appropriate services for them. And
right.
so other health reproductive healthcare needs that my research has found, in addition to just documenting this basic fact that pregnant individuals do exist in prisons and jails, and their pregnancies sometimes end while they're in custody in all kinds of ways. We've also
Mm,
done research to show that there's quite a lot of variability in the care services that are available, where some prisons and jails do provide access to prenatal care. Some provide access to abortion, and many, many do not. I've
mm,
conducted research on access to treatment for opioid use disorder in pregnancy, which the standard of care is treatment with methadone or buprenorphine for folks who have opioid use disorder. And that's long been the standard of care, that they should not go through detox or withdrawal. And yet my research, in which we surveyed all US jails, found that less than a third of jails provide access to medication treatment for pregnant individuals with this condition.
wow.
And so most of them require pregnant individuals to go through withdrawal or detox, which is far from the standard of care.
Yeah.
We've also conducted research on the need for and access to contraception, recognizing that this has to be thought of as part of the full scope of reproductive justice, that this is not talking about contraception. It cannot be thought of in a vacuum. It's also has to be in the context of ensuring they have access to prenatal care and safe birth and parenting options. But what we
Mm,
found is that there is an unmet need for contraception for incarcerated individuals, where many of them want to be on contraception when they get so that when they get released, they have a method of contraception to avoid pregnancy. Not
mhm,
all of them want to be on contraception, and even the ones that do not necessarily trust the prison or jail to provide that care to them non-coercively.
mhm,
But even the ones that do want to start it at the facility, we found that many facilities do not provide access to this care. So these are some of the things that my research has shown. In the bigger context of this, some of the demographics that foreground these reproductive health care needs are that most of the women, and I'm talking here about people who do identify as women, because that's what the studies have identified. Transgender healthcare is another issue as well. But most of
Yeah.
these women are younger than 45, so they are of
Mm,
potential childbearing age, right? And
mm,
then the last thing to foreground some of these reproductive healthcare needs that I've mentioned is that uh, women who are incarcerated are disproportionately women of color.
yeah.
Black women are nearly 2 times more likely to be incarcerated than white women, and American Indian, Alaska Native women are more than 4 times as likely to be incarcerated as white women.
Mm.
So there are tremendous racial inequity implications as well. And all of those reproductive health care needs and more that I've mentioned have to be thought of in that context of the racialization of mass incarceration.
Absolutely. I mean, such an immense compounding effect, right? Because you think about not only the overrepresentation of women of color in the, who are incarcerated, but also just the significant um, differences in, maternal mortality rates in terms of, systemic bias that exists all through sort of the reproductive care for women of color, particularly for Black women. I mean, it's just like it just keeps piling on, and
Mhm.
such a significant overarching effect. And I was also thinking about, I don't know if there's been um, research or if you've just anecdotally sort of seen this, but also just thinking about the history of um, just abusive behaviors, systemic abusive behaviors against Black and Brown folks by the medical profession that has led to such significant widespread distrust, right? Mass sterilizations and so on and so forth. And so I'm wondering, has that also sort of crept into the ways in which incarcerated women are thinking about or trusting the type of care that they might receive?
Absolutely. I'm glad you brought that up because there was an investigative journalist who, in collaboration with the nonprofit group Justice Now, uncovered cases of nearly 150 unlawful sterilizations of
Mm,
women in the California prison system between like 2006 and 2010. So
wow.
instances where women thought they were undergoing one surgery and had another, or were on the operating room table getting a C-section, and the surgeon said, "You want your tubes tied, right?" Or where they were
Mm,
consented for a procedure that they didn't fully understand. And this resulted in California passing a law a few years later that prohibited, still in effect, that prohibits sterilizing surgical procedures for the purposes of birth control or pregnancy prevention on people who are incarcerated in prison or jail.
mm,
And this instance, this, I don't want to call it a story because it's bigger than a story. It's the lives and reproductive capacities of dozens and dozens of women that were their reproductive capacities coercively taken away by the state. That is
mm,
part of a long history of and part of a through line of eugenics campaigns that seem like they're far in the past. And
mm.
it's really related to the present, and goes back, hundreds of years to the founding of this country in the ways that the
Yeah.
state has long controlled in one way or another the reproductive, or tried to control the reproductive capacities of people who are most marginalized by our systems of oppression. So it's, in direct through line with the ways that enslaved Black women's children were forcibly removed from them, the forced removal of Indigenous children from their families. This is all in continuity with that, and it may not have on the surface been with the same intentions, but it is absolutely part of the same history, and why we need to think of the broader reproductive justice framework and how those four core tenets of the right to have children, the right not to have children, the right to raise your children and parent in dignity and safety, and the right to bodily autonomy. None of those can be thought of in a vacuum. They're all connected.
Yeah. It strikes me too because what you were just sharing in terms of thinking about the long drawn out history of dehumanization and systemic oppression that I think so often, in my field of work, we find ourselves facing those who have just don't have that context then and have this perception, this false perception that history is in the past and that these things are no longer a problem. And so, just the this example of the widespread dehumanization of women in such a raw way, and taking away their their opportunity and their freedom to be able to uh, have some autonomy over their bodies and to be able to bring life into this world in a healthy way. I think it's such a profound story, again, that so many people are just not aware of.
Mm-hmm. That's right. I
Or,
would recommend for listeners the film The Belly of the Beast, um,
mm,
which is a documentary about the fight for legislation in response to these abuses, and it features the advocacy not only of Justice Now, but also of a survivor of coercive sterilization in the prison system. So um, it's very compelling. And, I told you the end of the story already that California did pass legislation. That's not news. So as you're watching it, you can know that there's a good outcome.
that's yeah. I'm glad that you shared that, and I certainly want to watch that documentary, and we'll put the name in the show notes for folks. Obviously there have been changes, there has been progress, and I would anticipate in a small way due to the work of you and many of your colleagues. What do you see kind of on the horizon when it comes to persistent and even future challenges that most need to be addressed when we think about reproductive healthcare rights for incarcerated women?
Well, I first want to give acknowledgement to previously incarcerated individuals who have led the fight on a lot of these issues and had great success,
Mm,
partly through the organization, the National Council of Incarcerated and Formerly Incarcerated Girls and Women, and then also at various state levels, previously incarcerated folks who've worked to pass legislation to prohibit shackling of pregnant individuals who are giving birth while in custody, legislation to ensure access to menstrual supplies while incarcerated, and not to be charged
mm,
for access to those. So I do want to give acknowledgement to the great work that they've done, derived from their trauma and their lived experience. And in terms of
yeah.
what's on the horizon and what we should be thinking of, there are several things that I want to highlight, mostly related to pregnancy and parenthood
Mhm.
behind bars. And one of them is thinking about alternatives to incarceration. I am all for improving reproductive health care conditions for people while they are behind bars. And I'll talk about that in a moment. But the big picture is that no matter how many improvements we make, no matter how much access to high quality medical care we provide, and we should be providing access to the highest quality medical care, these are still not places of healing. And we need to really think long and hard as a society about who we're incarcerating and why. And is this the right modality? And is this the right kind of institutions for how we want to manage certain issues? And I think ultimately, many people would say no. And most women certainly and individuals, are incarcerated for reasons that have less to do with them being threats to society and more to do with racial oppression and social disadvantage, that we need investments in more robust safety net and social services in order to not rely so much. And that's true when it comes to pregnancy and giving birth as well. And I want to give a shout out to um, the states of Minnesota and Colorado, which have recently passed legislation to divert pregnant individuals who've been sentenced to prison away from incarceration during their pregnancies and for 12 months postpartum. At least those are the specificities of the Minnesota law, so
Mm.
that they can be in community-based alternatives for their pregnancy, where they can be close to their support systems, where they don't have to worry about whether they're going to be shackled during childbirth, where they can have access to the prenatal care provider of their choice, and where they can breastfeed and bond with their baby for 12 months postpartum. So those kinds of visions of no births behind bars is one of the big picture items. But in parallel with that, and until the broader vision comes to fruition, we absolutely need to improve healthcare services and reproductive healthcare services, especially for pregnant and postpartum individuals behind bars. And this is where I want to highlight one very interesting legal particularity that listeners may not be aware of, which is that incarcerated individuals have a constitutional right to healthcare. So think
Mhm.
about that for a moment. We in the so-called free world may have access to healthcare, but it's not something that's guaranteed as a constitutional right. You become incarcerated, you lose most of your rights, but you gain this right to healthcare
Mm.
because the Supreme Court has determined that it's the state's responsibility. We're taking away their ability to access services, and therefore, it's the state's responsibility to provide them access to health care, and not to do so would be cruel and unusual punishment and a violation of the Eighth Amendment. But that
Mhm.
Supreme Court mandate from a 1976 case, it didn't come with a list of healthcare services that must be provided or any system of mandatory standards or a mandatory system of oversight. And so you get tremendous discretion and
Yeah.
variability from one facility to another, and some that provide access to a reasonable measure of quality reproductive health care, including prenatal care and access to abortion and postpartum care. And you get many other facilities that do not. And so I think one important step that we need is standardization, required standards, and access to community standard, full scope, comprehensive reproductive health care, just as if someone was in the community. One way to go about doing that is changes to Medicaid, because here's something else that people might not know. When Medicaid was created and Medicare in 1965 with an amendment to the Social Security Act, there's actually a provision in there that it's called the inmate exclusion clause.
Mm.
I don't like to use the word inmate, it's stigmatizing, but that is what it's called in
Yeah.
the amendment. And it specifically disallows Medicaid and Medicare funds to be used to pay for healthcare for incarcerated individuals.
Wow.
So there are some states that are applying for waivers for that so that they can uh, at least cover their care for 30 to 90 days before release. But we really need a full restructuring so that those funds can be used to pay for healthcare for incarcerated individuals. And then there might come with some measure of standardization and accountability. And then lastly, what I'll say when it comes to other things on the horizon, you brought this up a little while ago, and I'm glad you did, which is the necessity of thinking about mass incarceration, especially the mass incarceration of pregnant individuals and mothers and postpartum individuals. We need to think about this as part of the maternal mortality crisis in the United States.
Mm-hmm.
The United States has the highest maternal mortality rate of any high-income country, and it is not equally distributed. It
Yeah.
disproportionately impacts Black and Brown women, and and it tracks along the same lines of inequity and lack of access to care and disrespectful maternity care that
Mm.
incarcerated individuals experience. And while my PIP study didn't find any maternal deaths that occurred at our study states in one year, that was just a snapshot in time. And we also don't know what the impact is of being incarcerated during your pregnancy and then getting released, and what
Yeah.
your risks are when you leave.
Yes. I mean, you just, there were a couple of things that I wanted to highlight from what you shared. The first and foremost, I think There are, yes, absolutely, short-term solutions that you're naming in terms of ensuring that there is access to care. And we also need to keep our eyes on the long-term systemic change and the overhaul of the prison industrial system. Otherwise, we just keep recreating the same challenges and then trying to put band-aid fixes on them.
Mhm.
And that is, I think, where there's also such a powerful opportunity for advocates and activists from across a number of different uh, areas to collaborate on some of
Mhm.
these issues. And I'm wondering, where have you either seen already that this is happening, or what suggestions do you have? Who needs to be a part of this broader movement, and how do we bring those various voices together?
Yeah, well, I think this gets to the point of working in parallel and collaboration, that we can work towards abolitionist reimaginings of our systems
Mm-hmm.
and also work to make sure that people aren't dying and are getting the healthcare they need in the short term. And one
Yeah.
of the examples I have of those two together is the Minnesota Prison Doula Project and a nonprofit that they created, the Ostera Initiative. Um, so they are a group of doulas and also researchers, including my collaborator at University of Minnesota, Rebecca Schlafer, who started by providing doula care and doula services for pregnant women in the Minnesota prison system. And for those who aren't aware of what a doula is, they're a trained non-medical professional who provides birth support for people during their labor and childbirth, and also during pregnancy and postpartum. And so they created a program many years ago in the Minnesota prison system, and continue to provide essential support for individuals in the system. And also, they recognized this need for both and
Mm,
they were behind a lot of the work to get the Minnesota Healthy Start Act, which I described earlier, to divert pregnant individuals away from incarceration. And so they used their experiences of caring for people, and even with incredible support from the doulas, giving birth behind bars is still traumatic. You're still
right.
separated from your newborn after, once you go back to the
Mm,
prison after you give birth. And so they were able to harness what they've learned and work with previously incarcerated people. Some of their former clients worked with them when they got released, and they were able to utilize those experiences and their expertise to also advance legislation that is more aligned with reimagining a different kind of future.
mm. I love that example. And it speaks to the one, just how much opportunity there is for collective creativity when we sort of imagine what those possibilities can be. And also, again, I think it goes back to, I keep coming back to this idea of humanizing through these stories and reminding people that we are talking about humans. We are talking about humans who are giving life to other humans. And how do we want to, as a society, as a collective, take care of those humans who are creating life for other humans? So I wanted to ask you about the overturning of Roe v. Wade. And obviously, with the shift uh, to putting that, sort of that decision making power into the hands of states versus, having federal oversight, and numerous states now outlawing abortions at very early stages. How does this impact the work that you're doing and access to care for incarcerated individuals?
Well, there are a number of impacts that a lot of people probably haven't thought about. And while I don't have
Mm-hmm.
research data yet to understand that true impact, some legal and logistical factors to get listeners thinking about the impact at a very basic level. If abortion is not accessible in one's own state, in theory, you could travel to another state. People from Texas are traveling to New Mexico, to Colorado. It's not easy, but they have that option. If you're incarcerated, you can't leave. You're you're imprisoned.
Right.
You cannot
You
travel.
have no other options. Yeah.
And so it's basically foreclosed. Um, some people might say, well, what, maybe they'll get released. Jails are, especially jails are shorter term. Maybe they'll get released and they're still at a point in pregnancy when maybe they could travel to another state. Again, understanding that there are a lot of financial constraints to that travel. But if you get released
Mhm.
from prison or jail, chances are you're going to be on probation or parole, and you're not allowed to
And you
travel out
can't
of
leave the
state.
state.
And
Yeah.
so functionally, it's not accessible. That's just at a very basic level. But if you think about other aspects of abortion care that are necessary for pregnant individuals, there are also scenarios where um, abortions are emergently needed. And by the way,
Mhm.
all abortions are indicated, none are elective. They are all indicated. They're just indicated for different reasons. And so sometimes there are emergent medical conditions that require an abortion procedure, such as if somebody's water breaks and they're only 18 weeks, there's a high risk
Mhm.
of developing sepsis, and the pregnancy needs to be removed in order to prevent that infection, or sometimes even to treat the infection. Well, what we're seeing in states where abortion is effectively banned is um, that providers are not permitted to, or are confused about whether they are permitted to perform the abortion procedure. Even if it's to save someone's life, someone has to be, basically at death's door. And we've seen reports of that in the media, and in
Yeah.
court cases, people sharing their harrowing stories. Well, if you are incarcerated, and you have a complication, the facility, the jail or prison if you have a complication, will hopefully transport you to the nearby hospital. And if that hospital um, refuses to treat you, even if the prison or jail would pay for an abortion procedure for this individual, because it's medically necessary, if they get sent back to the prison or jail, those are not places that are equipped to deal with an obstetrical emergency or someone getting sick really fast.
Mhm.
And they don't necessarily have the resources to fly someone out of state for a medically necessary procedure. And so I worry about people languishing in prisons and jails, because community hospitals may not treat them. Um,
Mhm.
Another factor to, and I should be clear that this is at this point, just um, I don't want to say it's a hypothetical because I imagine it's happened, but we do not yet have any court cases or any publicly available reports of this. But it's very
Sure.
plausible. And then
Mhm.
another factor to consider is um, that unfortunately rape does occur in prison, or soon after, or soon before arriving in prison. And the Prison Rape Elimination Act, which went into effect in around 2003, but it's been around for a while. It has a provision there that says that if someone is pregnant and in custody and that pregnancy is a result of rape, they should have access to all legally available health care. Well, if in that
Mhm.
state abortion is not legally available, then the prison or jail is not obligated to give them access to abortion, or
Mhm.
maybe they're not able to. And then that person is forced to carry a pregnancy that was conceived in state violence because the state will
Yeah.
not allow them an abortion, because some states that ban abortion do not have exceptions for rape.
This is, I don't want us to end on in a bleak place. But I appreciate the fact that we need to be able to have these raw and realistic conversations about the ripple effects of the decisions and the policies that are being made, and how they're impacting a variety of different citizens across our country. What is your call to action, Carolyn, when you have conversations with, with those who do have the power to enact some change and make some significant progress? What what is your message, whether it's to leaders, to policymakers, to people who are involved in, across the judicial and justice system? What do we do?
Well, we need to ensure comprehensive reproductive health care access for people who are incarcerated. And for me as a physician and a researcher, that's my wheelhouse. And I advocate for those standards and what that looks like. And I will share in a moment I think a positive example, something to give us some hope. And so I talked to them about how harrowing it is to be a pregnant person, to give birth while incarcerated, although I've never been incarcerated myself. I also rely on the expertise of colleagues and collaborators who are brave enough to share their lived
Mm-hmm.
experiences. And I've
Mm-hmm.
seen that get policy passed. So I enumerate what standards of healthcare look like, and what it should look like. It's not just about passing laws, though, because, for instance, the issue of shackling, there are now 41 states, plus the District of Columbia, as well as the Federal Bureau of Prisons, through federal legislation that prohibits shackling of pregnant individuals, at least while they're giving birth. And yet it still happens. And so there's a lot of on the ground change that needs to happen, a lot of implementation. And so when I do that work, I do try the angle of, as you said, humanizing and remembering that, or reminding people that these are patients, these are humans, and they're giving birth. And even if they're not, they still deserve, both as humans and constitutionally, access to health care. One of the examples to give listeners just a little hope is the issue of access to menstrual supplies. This is something that hadn't been discussed much, certainly in some small circles, but hadn't gotten much discussion in the carceral healthcare circles or the policy circles up until, I would say, the last 5 to 7 years, when it's gotten a little bit more traction. And now there are over 2 dozen, or well over a dozen, close to 2 dozen states that have laws in place that require carceral facilities to provide access to no-cost menstrual supplies, because it's a health issue, it's a dignity issue. People should not have to
Yeah.
pay an exorbitant fee. Nobody should, but especially when you have limited means and when you
Right.
can't go to Walgreens or CVS to buy your own menstrual supplies. This is a serious medical need that facilities have to address. And not only do we have legislation, but I do have a story of hope that this is actually normalizing. I recently was presenting at a conference to a group of sheriffs, about 50 of them, who run large jails across the country, and this was one of the topics we brought up. And most of the jail leaders in that room had stories to share of, well, yeah, of course we do this. We didn't, but we recently changed, and it was not a big deal. And everyone was worried that people would hoard the supplies, but you know what? When you give them what they need, they just take what they need. And people are so grateful to have this basic thing. And of course, we wouldn't make them pay for it. It's like toilet paper. Would we charge them for toilet paper? I mean, there may be prisons out there that do. Um, and they described things like having like those Rubbermaid drawers that you can buy at the Container Store or Target, have them,
Mm-hmm.
in the bathrooms with tampons and pads. And even just having that visual, and having these sheriffs, most of whom were men, say like, yeah, of course we should be doing this, was really encouraging to hear that the laws are being implemented. And even in states where there aren't laws, it's becoming less of an issue and more of a no-brainer. There's still a lot of work to be done. This was, one small group of sheriffs at just a handful of the 3,000 jails across the country. So there's more work to be done, but it's absolutely feasible and something that ensures the health and dignity and safety of incarcerated women.
I will take any small, I think, any small win is still a win. And it is sometimes those small but not insignificant changes that can spark a movement, especially when it becomes, hey, we did this, it wasn't that hard, and of course, right, and then that spreads. And once you're doing that, then what else can be done that becomes just the norm? This is how we do things. And I wanted to just highlight what you said about it's safety and dignity, right? And can we remind ourselves that regardless of what has led people to be in the system, they are humans and they deserve safety and health and dignity. And so how do we do that in the short term? And then also, how do we begin the process of having those broader conversations around around changing the systems that perpetuate this oppression? You've given me a lot to think about, Carolyn, and a lot that I hope that I can bring into my own work and conversations with leaders, business leaders, and nonprofit organizations. And even I still think that the more that we talk about this and the more that we spread awareness, we never know where there may be those moments of, oh, that actually leads us to have an idea of how we can help to institute change. So I so deeply appreciate you taking the time and sharing your story and your research, and just the incredible changes that you have helped to affect in your career. And I wish you all the best of luck in the time to come. Keep going, because what you're doing is making such a profound impact for people who really need it.
Thank you. Thank you so much.
Thank you. Thanks for listening to the Culture Stew podcast. This episode was produced by MSM Global Consulting and edited by Robert Gratz. Interested in learning more? You can subscribe to Culture Stew on any major podcast platform and catch the video versions on our YouTube channel at MSM Global Consulting. You can also subscribe to our newsletter at www.msmglobalconsulting.com and follow us on LinkedIn and Instagram for more insights and updates. If you find this podcast valuable, please share it with your friends and colleagues. Until next time, y'all, take care.